So, thank you, Austin, again for joining us on one of our Zoom cafes for the MDS patient community. The session today will be, of course, about COVID vaccine, antibodies. We've had a few preliminary questions about those two topics, and then a couple of additional questions unrelated to COVID that we'll tackle. And mainly it is about the progress with the efficacy of the vaccine, the fact that you're working on the SOAP results and the SOAP analysis, which will be available hopefully sometime mid to end of August. So thanks again, and I've shared the questions, so perhaps you want to start answering those questions straight away.
Yeah, I can do that. Thanks, Sophie, and good to see lots of people. And some people might find it a bit boring because I only spoke to you last week, I think so, on Thursday in the Bournemouth South Coast Forum. But obviously today is a big day. Yeah, I don't know. It's called Freedom Day, I think so. But I think for the MDS patients and generally for the community of blood cancers or any other conditions which patients make their immune system compromised, I think we have to be still extremely careful, I think is the word, because it's great that most, if not quite a lot of the people on this call would have had both the vaccines. They will provide a degree of protection against getting severe COVID, because the fact that you do have vaccination and have good antibody levels doesn't mean to say that you will unlikely to get COVID, because that's something which is important to understand, because there is a possibility of getting COVID, but the complications of getting severe infection, hospitalization, and complications are going to be significantly reduced if somebody has been vaccinated, more so if you've had two vaccines going forward. I think what we are all debating about is the degree of protection. Say, for example, you are a 50-year-old or a 60-year-old, had two vaccinations, or is your protection going to be the same as somebody who's again 50 or 60 but does not have underlying MDS or conditions where immune system is compromised? So if the protection for the general public or the person who is the same age but doesn't have MDS is 80, 90, 100%, is your protection going to be 50, 60, 70% or whatever it is, or is it close to 80, 90%? So I think that is the major question, and that is what we are, thanks to you guys, a number of people on this call, that we are able to, we've been able to do a test. This I'm talking about the SOAP MDS. We have been able to do the test for your antibody levels and also other aspects of the immune system 2 weeks to 4 weeks after you've received the second jab, because generally uh, that will tell us whether the ability of the immune system to mount a protective response against COVID is is it at 60, is it at 70, is it at 90, or is it at 100%? So that's what the SOAP MDS study will look at. So just as an update, we've screened around 40 patients at a specific time point after receiving the second COVID vaccination to see the protective ability. So you would have noticed that I did not use the word antibody, because antibody is one aspect of the immune system which is measured to look at the response to vaccination. But there are so many other aspects of the immune system which we will be able to measure, including what is called as the T cells, which are another bit of the immune system which will look at the response or the protective response against COVID. So, which is why I would probably use commercially available antibody testing with a bit of a pinch of salt, because you could have an antibody test which will tell you, oh, you got good level of antibodies, but it might not be the protective level of antibodies. So it might be the test might say it is very strong positive, but in reality might be that your immune system might still struggle to cope with it. And the opposite is true as well, that you might have not have an antibody titer or an antibody which is positive, but your other aspects of the immune system, like the T cells and other things, will be very strong, that they might be able to protect individual patients against the risk of getting significant COVID and its complication. So I think some of the questions around it were anybody who's had double vaccine and their outcomes if they've had contracted COVID. So not particularly in patients with MDS. The SOAP study is not just on MDS. There is a wide range of cancers, wide range of blood cancers, wide range of other cancers like breast cancer. So there is one subset of the SOAP where the study is very much interested, because that's sort of going to be the real world going forward. You would have had two vaccines, you would have possibly had a booster. What is the chance that you could get a severe COVID or get complications due to COVID? So that is something which the SOAP study is particularly looking at, to understand what is different in this group of patients who have had both vaccines but still are contracting COVID and are getting admitted to the hospital. Yeah. So because nowadays we are seeing lots of people who have had two vaccines. Now I'm talking about not MDS or other blood cancers, just general public getting two vaccines and still able to contract COVID and also get symptoms related to that. But for blood cancer and other cancer patients, this is something we are looking at in the broader context of the SOAP MDS study. And there were some questions about updates regarding COVID, because it's a general landscape, is it? Because we know we are getting 40 to 50,000 infections every day in UK, but till date it is not significantly translated into hospital admissions, although we are slowly but surely seeing an increase in the hospital admissions as well, and a proportion of those patients are double vaccinated as well, have had two vaccinations. So that's what we are looking at. There are a number of different studies which are evaluating antibody responses and immune system responses in patients who have had vaccination, including transplantation as well. And there are a number of studies which are ongoing both in UK and worldwide to assess the response of vaccinations to it as well. So I think in a couple of months we'll be a bit more clearer, prior to hopefully the uh, planned rollout for an autumn booster or early winter booster of the vaccination, with and without the flu vaccination. So we'll be able to have some data, some scientific data, to guide us to see when is the right time to boost the vaccination, and also to see whether how long lasting the response will stay, because that's the important thing, because it doesn't mean to say you've had 2 vaccines, your vaccination levels or antibodies or however we measure the immune system, you're very well protected, but it could wean down or go down as time goes along. Yeah. Would it be 6 months? Would it be 9 months? Current data seems to be that at around 6 to 9 months, the response starts to go down. Yeah. And just as a piece of information, patients who have COVID infection seems to have at least a 3 to 4-fold higher antibody response rather than patients who've had 2 vaccines and didn't have the COVID infection. Doesn't mean to say we need to get the COVID infection because the antibody levels are higher. It doesn't mean to say that, but what I'm saying is the natural antibody response seems to be extremely higher compared to the vaccination, which is not surprising because there is a reason for that. Yeah. Um, uh, I, again, the testing for routine antibodies, I would always take it with caution because you don't know which lab it's done. We don't know what antibodies they are checking. We don't know what time point that antibody is done. And again, as somebody has asked in the question, it's never an yes or no answer for antibody, because you could sometimes have an inconclusive result or an indeterminate result, which doesn't mean anything, because it is important that those results are interpreted with caution as well. So what I would personally say is that have both vaccination. We don't know, we do not yet know the proportion of patients who will respond to the vaccination, but we will know that soon. Continue to be extra careful, extra vigilant. I wouldn't go as far as I saying that you continue to be rigidly screening. This is again my personal opinion, but I would always say if there is a halfway house between totally locking yourself in the room and being totally vigilant and be not interacting versus going all out and without masks and other things, if there is a halfway house somewhere, that's where I would say that we should all as MDS patients should fit in. Yeah, try to be very careful, but try to be also be extra vigilant as well. And unfortunately, I don't know why the policy of the government is as it is, but because as you probably know, the masks are important predominantly not to protect yourself, but to protect other people from getting infection from you. So if you flip the coin, it's the same, because you as patients would want to see people around you wearing masks rather than, it is important that you wear a mask as well, but the protection ability is more when somebody else is wearing a mask and they're not able to give it to you if they have a mask. Yeah. So a couple of other questions which came up was uh, can GVHD arise after many years of remission? I think it can, because sometimes it's a GVHD unlikely, but there have been cases where there has been flare up of GVHD due to a different trigger. It could be an infection, could be a vaccine, could be unknown triggers as well. Sometimes we've seen that. I don't know what the current policy is for shingles vaccination in a transplant. I don't think so. We routinely recommend, I think so, because of its new, and I don't think so. The only live vaccine we recommend is the MMR vaccine. We do not recommend shingles vaccine unless the policy has changed in the last
It,
few months, 2 years.
it hasn't, Austin, not that I'm aware of, so we're still sticking with the policy of not having shingles vaccine.
Yeah. Good. I think those were some of the general, generic questions around it, but I'm happy to take any further questions if you've got. Apologies, I'm being a bit sort of wishy-washy because we don't have the results for me to confidently tell you this is what we stand.
Yes, thank you. And I did explain at the beginning that we don't yet have those results, but yeah, you've promised to come back end of August, probably, as soon as those results are available, and we're very grateful for that, and we're planning a big meeting at that point. I was going to say with David Bowen and Dominic Culligan, yourself also, there was maybe a talk about maybe identifying some patients who might be a little bit more at risk and some a little bit less at risk. Maybe patients on treatment, patients off treatment. Is there any difference there? I know that all the experts were thinking of possibly getting together and doing a hierarchy of risk, if that's possible at all.
Again, it is possible to do that, but again, it's going to be such an arbitrary classification based upon clinical expertise without significant knowledge specifically into the question we are trying to address. Yeah. So what has been shown in other diseases like lymphoma and myeloma, which are two other different types of blood cancers, is that people who have more higher risk disease or who have been recently treated with antibody treatments and chemotherapy treatments seems to have a lesser ability to mount a response to the vaccination than people who are on a watch and wait strategy. So if you want to sort of transcribe that directly to an MDS population, so potentially people on watch and wait on treatments like EPO and GCSF might potentially have a better ability to respond to vaccination than somebody who's on intensive chemotherapy or chemotherapy. And we don't know where azacitidine falls under. Probably it falls somewhere in the middle. But again, those are the things we potentially could have could have uh, could want to do it as a consensus statement, but uh, without having data to back us up.
Yeah, absolutely. Thank you, Austin. There's also there's been an unfortunate statement by Public Health England and the ONS, the Office of National Statistics, saying that all vaccines seem to be working for everybody. So we're trying to campaign to get that sort of retracted together with all the other charities. And Christine was also asking whether that the information is actually collected and fed back to Public Health England and the Office of National Statistics for them to clearly understand a little bit better what's going on.
Yeah, it is. I think so. But the hope is that these data will be out soon to indicate how many patients were double vaccinated who were admitted, just generically rather than having blood cancers or not. But anybody, because that's where people are more keen to do more research and studies into it. Because why would they get severe infection? Or why is that? Because they have not mounted a response, or they mounted a response and lost the response. So those kind of things are some things people are at the moment looking to study further so that we can understand better on this particular concept.
Okay, thank you. Does anybody have additional questions that they haven't submitted on their at registration? I've got Christine with her hands up, and we've got a chat question from Gerard. He's a bit concerned because he's not had any bloods done for 18 months.
Yeah, I think it's sort of, we are in a stage where we are slowly trying to see most, if not all, patients. Some patients have got a very good system of the GPs doing the blood test at every 3 to 6 monthly intervals and routinely sending it forward to us. I know it's not ideal, but that's probably the closest best thing to directly seeing patients in the clinic. But quite a lot of the centers, including us, we are slowly trying to see patients directly face to face at least once a year as well, if possible, so that we can yeah, one, we can see how you guys are all. Number two, it would be a bit more of a reassurance, and it's also great for patients as well, is it? It's sort of reassurance aspect of it as well. because I keep all the time saying, I think it's fantastic to have the blood test and other things, but it's not the same as seeing patients with the blood test as well. So it's a slow process, and we are getting there.
Okay, thank you. Yes, we had that presentation by Oxford to analyse how remote consultations were working and telephone consultations, so it was definitely mixed feelings there. Christine, do you want to ask your question?
Hi, yeah, it was just, and I'm sorry if I've said this on other meetings, but there are so many different people on different meetings, so I'm sorry if I'm repeating myself. But Austin, I think you'll probably be interested in this. Obviously, it's anecdotal, but my brother and sister-in-law, who are both double vaccinated, met indoors, ironically, for the first time a few weeks ago, with two friends who are also double vaccinated. One of whom actually is a GP, so would be very well aware of, um, precautions and in her job. But anyway, 2 days later, she tested positive, and one by one, my brother-in-law and then sister-in-law tested positive. And obviously, the good news is my brother-in-law is mildly immunocompromised in as much as he had a lot of lymph glands removed because of a melanoma a few years ago, but they're not quite sure how that affects his immune system. But both of them, I would say, probably had a mild disease and weren't hospitalised, but it wasn't very pleasant. They had the loss of smell, loss of taste, loss of appetite, and overwhelming fatigue for 2.5 weeks. So I think that shows that maybe, unless it was just an unlucky chance, that shows that the vaccination doesn't prevent transmissibility particularly well, as they were only indoors. They were old as well. They weren't having it large, as it were. But the worrying thing is that had that been a meeting with somebody like me or any of us, what might the outcome of that have been, because of the doubt, obviously over our response to the vaccine. So just by way of saying that, I'm sure nobody here is thinking that, oh well, we can all go indoors now. I would just say exercise great caution, because it just goes to show that it is still being transmitted, even though that hopefully it's less serious. But we don't know with us whether it will be less serious, and that's the worry, isn't it? So.
Yeah, totally agree. That's always the worry. And like what you said, Christine, that it's it's not that the vaccination reduces transmittability. Yeah, it doesn't totally abolish transmission at all. Number two is vaccination doesn't prevent somebody from getting a COVID. It prevents severe COVID infection and hospitalization. So that's what all the data shows. But what you're trying to say is quite right. Like, severe for an immunocompromised patient is fine, but that even if it's a mild to moderate for a patient whose immune system is down, there is more chance it will become severe and get more complications. So that is always the biggest worry, and we should be vigilant about, I think so. And yeah.
Yeah, I mean, this is the area that the general public sadly doesn't understand very well, or chooses to ignore, because everybody's fed up with being in lockdown. But it's thankfully the media is making a lot of noise about this, and it's really important that just everybody understands that not wearing a mask in public places is putting people at risk. There's Fiona that asked the question whether SOAP covers transplant patients, or are there other studies that are looking at transplant patients specifically?
Yeah, so Fiona, good to see you. I don't think so. Yeah, SOAP doesn't cover transplant patients at all, although there are definitely other studies. Is it Octave or something? Is it, Sophie? And there are other studies which are covering post-transplant patients.
Yeah, I think for detail, there's probably our colleagues at Blood Cancer UK have got a blog that covers absolutely every study, and transplant will be covered as a mixed group by some of the other studies. Include with myeloma and lymphoma or any other blood condition where transplant is included. I think Tony Paluca is also looking at that, and certainly I know that there's a few of the transplant experts in the vaccine, what's it called, the vaccine consortium that is has been put together by Blood Cancer UK, and I'm pretty sure Tony Paluca at King's is part of that as well. So yeah, and somebody at Oxford, Karthik Ramasamy, I think, is at Oxford is included in that as well. So yeah, we'll try and cover all of that, but again, yeah, it would be good to have something that is MDS specific again, because it's we want to see if there's something different. But I'm sure the Octave study will do a sub-analysis of the different blood diseases within their own study. But I'm not sure at the moment how many MDS post-transplant MDS patients were included in those studies. That's always a little bit tricky.
May I ask a question?
Of course, go ahead, Subhadra.
Yeah, I'm about nearly 7 years post-transplant, and 7 years post-transplant. Oh God, go away. And yeah, and I'm considering whether I should go into church, where they're now saying you don't have to wear masks. But I would always wear a mask. And I'm not quite sure whether I should be in a surrounding like that, because I think since I had my vaccination, I had 2 GVHD episodes flare up. So should I? Is it a decision I got to make? I know I'm 7 years post-transplant and I have been well, extremely well. Not even a cold, but I have been careful.
Yeah, again, it's sort of it's a difficult choice for you, because at the end of the day, it's your individual decision to make that call. Although I totally understand it's a difficult one. I think if they're following the government advice, then you don't need to do anything. But I am aware that number of their individual institutions, individual organizations are putting the things in their own strategies, because I sort of, for one, remember, I know that there was somebody mentioned about a church where they're going to have different types of lanyards, red, green, and yellow. So red, green, and amber is it. Green is like, I'm not bothered, then I can interact with people. Red is, stay away from me, leave about 4 or 5 seats around me empty. So I think different people are having different strategies of things. So I think it is individually up to you. I would see how things go and then make a call, because if something happens, then you're concerned. That is why you had it. Plus, I think the worst scenario at the moment is, it's not only that, it's just we are going into potentially a third wave or a peak, is it, with the cases going up. And that is the difficulty, because if this third wave was not peaking up and the incidence or the prevalence in the population was low, then I would have been a bit more less cautious. But because it's come at a wrong time, that is the biggest difficulty, because with cases going up as well, and releasing all these immunocompromised patients into the public pool, that is the difficulty.
Thank you. I found that very informative. Thank you.
Yes, and
And I
of course,
think I'll make the decision not to go, unless most people, like before, they were wearing masks. And yeah, thank you.
you're welcome, Subhadra. I think, yes, it depends really on the place that you're going to. Some places like supermarkets, some supermarkets have started to accept that or will recommend that their customers wear masks, and London Transport as well. So any sort of pressure on asking the general public to do that will mean more protection. And you could make a special request to your church, who may not understand these things properly. But I would imagine that being a church and being thoughtful and careful about their attendees, they would make an effort. As Austin says, there are these lanyards that some people introduce. There are other people who are starting to wear badges. Please be careful, I'm shielding, keep away, I'm shielding. Things like that may help, and I think we shall start seeing more and more of these. And just to come back to what Austin was saying, yeah, we don't yet know what's going to happen, and especially with the variants. I haven't followed the exact signs, but if the Delta variant is behaving differently, we don't know yet. And after all the youth has come back from their partying last night, we will have to be very careful. Chris, you have another question.
Yeah, I was just thinking about sort of what Austin said, which is absolutely the case, that, you know, obviously the more people there are out there, and something that has concerned me is that amongst vaccinated people, the symptoms have been shown to be rather different. I think anybody who's on the Zoe symptom study will have read that they tend to manifest themselves sort of rather differently, and I think the danger is that there will be more people walking about thinking they've got a summer cold, you know, they've been sneezing a lot, and thinking, oh, I'm fine, when in fact they may actually have, you know, very mild COVID, and be less inclined to test themselves or to sort of take any precautions. So, you know, I mean, pre-vaccine, you know, if someone's near you literally coughing their guts up, you think, oh, I'll keep away from you. But if someone's near you and they're just a bit sniffly, I would sort of say to people, well, you know, it might not just be a sniffle, or it might not be hay fever, it might be something else. It's like the problem with children, isn't it? They don't quite know what the symptoms are in young children. So I have to watch my grandchildren, because, you know, they may have just a cold, but it may not be just a cold, it could be something else. So I think you just have to say to people, you know, if you're not 100%, stay away.
Yeah, I agree. So I think the symptoms, there are now so much changing spectrum of symptoms, because patients who have 2 vaccinations have a different symptoms. Patients who have Delta have a different symptoms. Patients who have Delta plus variant might have different symptoms. So this just keeps changing, because like what you said, Christine, like if you're just sneezing and just being snotty, people always felt it's not COVID, but we've been proved wrong in the recent past as well. So it keeps changing. I think recommendation for children and family members is always a difficult one, because we usually rely on the government to sort of say what recommendations would they give. But if they are saying all sorts of things which we don't agree with, then I'm not sure whether we should rely on them. I think so. I think we should just be extra cautious, because they are the people who would bring in things from outside, because you might be cautious, but you might be the secondary recipient of what they bring in. So I think it's worth to be cautious, I think so. Yeah.
Yeah, and same thing with employers. So that's particularly a problem if your spouse or adult child lives with you and goes out to work, it is particularly tricky. And again, the government hasn't made preparations for that particular situation. But you would say, Austin, just keep the distance and from those people who live with you, unfortunately. Yeah, and people with young children going to school as well. And we've got a couple of so one of the things that we're trying to say to all our members is to also communicate with their MP and state that if you haven't yet done so, write to your MP and say that how MDS and the current situation is impacting on your life. That'd be very important. Karen is just need to leave, so you need to go back to work. Karen, nice to see you.
Thank you, everybody. Take care, everybody. Bye.
Bye, Karen.
Bye.
And Neil was saying something about an armband that UCH has. Do you want to tell us a little bit about that? Oh no, it's from Christine Peel. Sorry, Neil isn't on the call today. Yeah. Okay. Are there any other questions for Austin? It can be again related to MDS, to COVID, or purely related to another MDS topic. You can type it in, or you can wave your hand. Mary, sorry, I've got you there. I've had to change views. Go ahead, Mary. You're muted.
She might have frozen out.
Nope.
So,
Can you hear me now?
Yes, loud and clear.
Oh, good. You were talking about the shingles vaccine and not having that, which was very interesting. But I had it about 2 years ago. So I'm just wondering whether that made any difference or not. That's all. I'm just intrigued to know why we shouldn't have the shingles vaccine.
So generally, it's been thought that in patients with a compromised immune system, having any kind of live vaccination can be significantly associated with complications and risk. So that is the general theme which has been around for some time, and more so shingles vaccine has been only around for last, I say recent past, but it's been around for 5 to 10 years, I think. So I think that is the major reason. And anything, it's a risk-benefit ratio, is it? Like, would you weigh up the risk of getting a shingles versus what the complication the vaccines can do? So that's always weighing up the risk-benefit ratio and finding out what is appropriate. So, which is the reason a number of centers do not give shingles vaccination for MDS patients, and also for post-transplant patients as well.
Well, I hadn't got MDS when I had it, so maybe that was.
Oh, that explains.
That explains it. Okay,
Yeah.
thank you very much.
And I don't think so you're at increased harm or risk now because you had it before you had MDS. No.
Yeah, okay, thank you very much.
I've just posted also in the chat the article that we had on our website a while ago on shingles and the vaccine. Shingles vaccine, not the COVID vaccine. Okay, we've got just about 10 minutes or so to go. Are there any other questions for Austin? Again, he will join us for a really in-depth session in August. to discuss the results, and we can bombard him with questions at that point. So if there's anything unrelated to COVID, maybe. Donna, are you waving or you... No, that was a fly.
Sorry, yeah, it's a fly.
Okay. Nobody else with any questions? That means you've done a great job, Austin, at
Or I've
explaining.
had enough of media things, says it. No, it's fine.
Barbara shakes her head violently. Definitely not.
No, thank you.
Thank you
Good
so
luck.
much, Austin. We'll let you run back to the clinic or the consultation, or for some lunch probably. So thanks again, and we'll be in touch regarding an exact date in August.
Indeed. Take care. Bye. Thanks.
Thank you, Austin. Bye bye.
Thank you.